Hello my dear friends, I welcome you all to my daily dose. I am myself Dr. Rajesh GUBBA. I am the general medicine educator. So as the part of today's daily dose, I have a 33-year-old man travels to South Africa to take part in a safari. On arriving, the patient takes his anti-malarial tablets. A few days into his course, he becomes ill, complaining of shortness of breath, pallor, and bloody urine. Blood tests reveal anemia and reduced hematocrit, while the blood smear shows the presence of the Aiims bodies. What is the most likely diagnosis in this patient? The options are hereditary elliptocytosis, G6PD deficiency, hereditary spherocytosis, autoimmune hemolytic anemia, microangiopathic hemolytic anemia. So, if you take this question, after consuming this anti-malarial tablets, after few days, the individual has developed symptoms like shortness of breath, pallor, and as well as bloody urine. And blood smear, it is showing the presence of the Aiims bodies. So what is the diagnosis? So in this question, the answer to this particular question is the G6PD deficiency, right? Now, which all the anti-malarial drugs will cause this particular clinical scenario? It is mainly the drug primaquine, and we have one more anti-leprotic drug, that is dapsone. So these are the two drugs which will cause this particular clinical scenario in a patient with a G6PD deficiency. Now, what exactly is the importance of your glucose 6-phosphate dehydrogenase? Let me tell you. See, glucose 6-phosphate dehydrogenase, it's an important enzyme which is required to maintain the adequate levels of glutathione. Now, what is glutathione? Glutathione, it is an antioxidant, right? It is an antioxidant. What it will do? This glutathione, it will prevent the denaturation of the hemoglobin, right? It will prevent the denaturation of the hemoglobin which is present in the RBC. Now, when there is G6PD deficiency, that will result in decreased levels of your glutathione, and thereby the RBC, it faces the oxidative stress. Now, once this RBC faces this oxidative stress, the hemoglobin undergoes denaturation, following which there will be formation of the Aiims bodies. Okay, so the presence of the Aiims bodies is a very important feature which is suggestive of the G6PD deficiency. Then you take the other options, that is hereditary elliptocytosis. Hereditary elliptocytosis, let me tell you, this is very commonly associated with the iron deficiency anemia. And in these patients with the hereditary elliptocytosis, there is no additional oxidative stress, right? There is no additional stressors of oxidation in case of hereditary elliptocytosis. You take the other option, that is spherocytosis. In spherocytosis, the biconcave shaped RBC will become the spherical shape. And why is this? This is mainly because of the spectrin deficiency within the cell wall. And thereby, this particular RBC, once they are passing through the spleen, they become highly fragile and they get ruptured, right? They get ruptured. That is what you will see in hereditary spherocytosis, and they are not subjected to any oxidative stress. Then you take autoimmune hemolytic anemia. The word itself tells you the antibodies, they are formed against the RBC, and these antibodies which are formed against the RBC will cause the lysis of the RBC. That is what is called as autoimmune hemolytic anemia. Next one is the microangiopathic hemolytic anemia. In microangiopathic hemolytic anemia, what does the peripheral smear show? The peripheral smear, it will show the presence of the schistocytes. It is not the Heinz bodies. So that is the reason why your microangiopathic hemolytic anemia is also ruled out. So going back to the question, this particular patient, after consumption of anti-malarial tablets, probably primaquine, has developed this particular clinical manifestations, and that would be because of the oxidative stress in patients with the G6PD deficiency, wherein there is denaturation of the hemoglobin, resulting in the appearance of the Heinz bodies on the peripheral smear. So that is about the explanation of this question. Now we will move on to the next question. So if you see the next question, I have an 18-year-old African man presents with worries about his general health, stating that hypertension and sickle cell anemia are present in his family history. Now the patient denies any shortness of breath, chest pain, digits or limb changes. That means he is completely asymptomatic. But the only thing is he is worried because he has the family history of sickle cell anemia. Blood pressure is fairly normal, 124/77. What test would be appropriate to investigate sickle cell anemia? Now, see, if this particular patient, if he has sickle cell anemia, it would be very easy to just examine the peripheral smear and then confirm the diagnosis as sickle cell anemia. But the individual is asymptomatic. So that is the reason why still that particular sickling might not have been developed. Now, what you have to do, you have to induce the sickling, right? You have to induce the sickling. Now, in patients with a sickle cell anemia, let me tell you that if the individual is exposed to hypoxia, if there is reduced oxygen in the individual, there will be acceleration of the sickling. Even the normal biconcave RBC will get sickled if the individual has sickle cell anemia and if he is exposed to hypoxia. Now, how to induce that particular hypoxia? We use this metabisulfite. Now, what this metabisulfite will do? This metabisulfite, what it will do is, it will mimic accelerated deoxygenation. So what it will do is, it will make the RBC to have an environment being exposed to less oxygen, and thereby now we will see if there is any development of sickling of this biconcave RBC to sickle shaped. So that is what is your sodium metabisulfite test. Whereas you take the other options, that is Aiims test. Where do we do this Aiims test? We do this in patients suffering with paroxysmal nocturnal hemoglobinuria, where there is excessive hemolysis mainly during the night time. And you take the Schilling test. This is mainly being done in patients with B12 deficiency, where the individual will have development of megaloblastic anemia. Right, where the individual has development of megaloblastic anemia. That is what is your Schilling test. Next, you take the Coombs test. Particularly if you take this Coombs test, we have two types. Direct Coombs test and as well as the indirect Coombs test. Right, direct and as well as indirect Coombs test. So if you take this direct and as well as indirect Coombs test, this is mainly to investigate the autoimmune hemolytic anemia. Right, this is mainly to investigate the autoimmune hemolytic anemia. Whereas you take this osmotic fragility test, this is the test which is particularly useful in the individual suffering with the spherocytosis. So in spherocytosis, just now I was discussing in the previous question, these spherocytes, they are highly fragile. Right, they are highly fragile. Okay, so this osmotic fragility test is used to investigate the hereditary spherocytosis. So going back to the question, so in order to check whether the individual is having this particular sickle cell tendency, we need to do sodium metabisulfite test. The other options like Aiims test we do for paroxysmal nocturnal hemoglobinuria, Coombs test for your autoimmune hemolytic anemia, particularly direct Coombs test, Schilling test for B12 deficiency, osmotic fragility test for hereditary spherocytosis. Now we will discuss some of the single liner questions. What is the drug of choice for idiopathic intracranial hypertension? See, the drug of choice for idiopathic intracranial hypertension is the acetazolamide. Acetazolamide has found to be the best drug to reduce the intracranial hypertension and to reduce the headache in the individual. Now, for suppose if the individual is intolerant to acetazolamide, then what is the next option? If the individual is intolerant to acetazolamide, the other option what we have is the furosemide. Right? Next. Now, the headache of this particular individual suffering with the intracranial hypertension, it mimics migraine. Right? It mimics migraine. So the differential diagnosis of your idiopathic intracranial hypertension is the migraine. So for migraine, like what do we give? The prophylactic drugs like beta blockers like propranolol can be given, and we can also give amitriptyline, which is a tricyclic antidepressant. Right? Next. Now the same patient of this idiopathic intracranial hypertension, if he is having any visual loss, right, if he is suffering with the visual loss in either a single eye or both the eyes, then we need to give high dose steroids. Right, we need to give the high dose steroids. So these are the drugs that need to be given in individuals with idiopathic intracranial hypertension suffering with the visual loss. Next, like okay, you have given acetazolamide, but still the individual is deteriorating. So in spite of medical management, if the individual deteriorates, that is the point when you need to do a surgical correction in the individual. Now, what are the surgical treatment options for idiopathic intracranial hypertension? The surgical treatment options is number one, decompression. What is the decompression you will do? You will do a optic nerve sheath fenestration. So by doing this particular fenestration, the pressure over the optic nerve can get reduced. And the other one is you do diversion of the CSF by doing the shunts. Which particular shunt? Ventriculoperitoneal shunt, where you will put a shunt in between the ventricles of the brain and as well as the peritoneum, where you will cause the diversion of the CSF. And the other one is lumboperitoneal shunt. So by keeping this ventriculoperitoneal and lumboperitoneal shunt, you can cause the diversion of the CSF and thereby reducing the intracranial pressure and thereby reducing the headache of the individual. So this is one of the options which you can make the individual with idiopathic intracranial hypertension to get relieved. So in this particular question, drug of choice for idiopathic intracranial hypertension is acetazolamide. Now you take the one more single liner questions. Ipsilateral third nerve palsy with ipsilateral hemiplegia is seen in. Now this question you need to understand properly. Both are ipsilateral. The cranial nerve involvement is ipsilateral and as well as the hemiplegia is also ipsilateral. Now where will be the site of lesion? The site of lesion is in the uncus. Uncal herniation is the one which will cause ipsilateral third nerve palsy with the ipsilateral hemiplegia. Now what is this particular uncus? Uncus, it is the part of the parietal lobe. Right, uncus, it is the part of the parietal lobe. Alright, so once there is an uncus herniation, that will go and cause the compression over the midbrain, the same side. Right, that will go and cause the compression over the midbrain, and that is the one which will cause the third nerve palsy. Right, that is the one which will cause third nerve palsy. Whereas cingulate herniation, it is mainly the part of your frontal lobe. Then what is that you will have in Millard-Bugler syndrome? In Millard-Bugler syndrome, the cranial nerves that will be paralyzed is 6th and 7th cranial nerve. Right, 7th cranial nerve, and the motor involvement, that is hemiplegia, will be contralateral hemiplegia. Right, there will be contralateral hemiplegia. Where is the site of lesion in these patients with the Millard-Bugler syndrome? In these individuals, the site of lesion is in the pons. Right, it is one of your pontine syndrome. Then you take the Weber syndrome. Weber syndrome, the site of lesion is in the midbrain. The cranial nerve involvement in this individual will be the third cranial nerve, and this individual, they'll have contralateral hemiplegia. Right, they'll have contralateral hemiplegia. So ipsilateral third nerve palsy, contralateral hemiparesis or hemiplegia will be there. So going back to the question, ipsilateral third nerve palsy with ipsilateral hemiplegia is seen with uncal herniation. So these are some of the single liner questions. So with this, I conclude my clinical based questions and as well as the single liner questions. So for more multiple choice questions, videos and notes, you have to download and subscribe to Medicine Made Easy app. Thank you very much.